So what does it even mean when we say you're seeing eye floaters or I'm seeing eye floaters? It is a valid diagnosis, but what does it really mean? Well, the answer, like many things in life, is complex. Hi, I'm Dr. James Johnson. I am also known as the Floater Doctor. This is another episode in an ongoing series of a masterclass for the management and treating of eye floaters. This is intended for eye doctors, but I know I have visitors here suffering eye floaters. So what does it even mean when we say we're seeing floaters? Well, let's go to first principles, let's go to basics, and let's talk about what is even vision, okay? This is not entirely comprehensive. It's kind of simple, but for the purposes of evaluating floaters, this will be pertinent. And we do have to think about floaters differently from the way that we think about, what is vision. So first, I want to talk about what we would traditionally refer to as vision. And that would be, we have either an object in three-dimensional space outside of our eyes, in this case, a simple little tree, and in complete pitch black darkness, we can't see anything, so we need a light source. In this case, we have the sun. So the sun is sending photons in every direction, light rays, represented as light rays in every direction, and it will strike the leaves of that tree and the structures of that tree, and it will be reflected, again, in all directions. And if you're far enough away from that object, you'll have essentially parallel rays of light entering towards that eye, and then the light rays will be bent and fracted by the optics of the eye and then focused onto the retina. This is and both of these examples will be positive phenomenon. That is, we have a light source, we have photons, we have light rays, and they will send that light energy, and then within the structure of the retina, the rods and cones will take that light energy and say, oh, photons, let's do something with this. Let's process it. Let's send that information electrically through the nerves, through the optic nerve back to the brain, and the brain can assemble that and say, in my experience, that looks like a tree. So that's how we see a tree. Now, we might have a direct source of light, of those photons, in this case, a little light bulb. And when the filament heats up, it's sending light rays and radiating in different directions. So we'll have a direct source rather than a reflected source. We'll have a direct source heading towards the eye. And again, similar process, the optics will refract and bend that. These are exoptic, which is a term never used, exoptic sources of vision. It's what we would traditionally describe as vision. When I look around the world, I see things, and in my experience, I'll say there's a chair, there's a tripod, there's a microphone. That's how we see light. So that's not how floaters work. But also in this category of positive phenomenon, we could say there's also entoptic sources of light, we'll say. And it's positive as compared to negative, because I'll talk about negative in just a moment. So positive source of light is various levels of brightness that are being perceived. Now, what if the source of that light comes from inside the eye, from within the optical system? Then it's entoptic. So maybe some of you have noticed, once in a while, in the middle of the night, you rub your eye and you're like, well, that's kind of weird. I'm seeing a little light over on this side. As I stimulate the retina on this side gently, don't do this at home. I'm a paid professional. You rub your eye a little bit, and you'll actually perceive that there's light coming from the other side. And although this is further back, I'm actually pressing up front here. But if I'm rubbing the eye, I'm stimulating the rods and cones in that particular part of the retina. Well, that particular part of the retina normally would see way out, would perceive light coming from the other direction. So it's a way of fooling your brain, which is, the retina is topographically oriented, left, right, up, down. That part of the retina has been fooled and falsely stimulated into thinking that it's seeing light out there. So you can do that externally. If you've ever, bumped your head in the middle of the night, it happens. That might be that. Now, from within inside the eye, and this is much more common probably, is during the process of a posterior vitreous detachment. So without going into the details of a PVD, a posterior vitreous detachment is when this sac which contains the vitreous starts to separate. And in sort of cartoonish simplicity, I'm representing this membrane peeling away from the back of the eye there. Now, on this side, it might have completed. The vitreous base here remains attached, so it's actually completed and fully separated. Over here, it has not. And in this area here, it might remain attached to the retina. And from the inside, as you move your eyes and back and forth, this membrane might pull and tug on the inner retina here, and that traction is perceived by the rods and cones as a source of light. They're being stimulated, and the retina says, I don't know what's going on, but I'm seeing light. And since this interface is usually, as that membrane peels away, there's an interface that is peeling away, it will often be seen as a brief arc or flash of light. So both of these are positive visual phenomenon originating at the level of the retina, one from external, one from internal pulling and tugging. Hopefully that membrane will separate completely, and when it does, no more flashes of light because there's no more attraction. So very commonly when people get a PVD, they might describe peripheral arcs, flashes of light, at nighttime driving. They look over their shoulder and they get a little flash of light and they think there's lightning or something like that. That's very, very common. So these are all positive. What are negative visual phenomenon? Well, negative, not in the sense that it bothers you and I have a negative feeling towards this. A negative phenomenon is the absence of light or a reduction or diminution of the amount of light or the quality of that image. Okay? So let's say you have a scar, a missing area of retina, that would be called a scotoma. That would be an area of without vision, right? That would be a missing area. Kind of like having pixels missing from your screen. That's not really what we're talking about. In the case of eye floaters, you have something that is optically denser than the surrounding area. That could be very dense. It could be loose and diffuse, a light cloud kind of spread out there. It could be just that membrane that has separated, like I described with a posterior vitreous detachment. Since you can't make the vitreous clearer than clear, it can only be less clear than that ideal youthful state of clarity. So as those light rays are trying to pass, they go through the optics, they're first bent and refracted at the level of the cornea, bent and refracted again at the lens, and they're trying to make their way to the retina there. Anything intervening in that space has the potential to reduce the quality of that image. That would then be a negative phenomenon. So eye floaters, by definition, are some sort of density within that vitreous space there. They will reduce the quality and the clarity in the ideal state of vision. Now, there are many, many, many variables that affect how that negative phenomenon, that clouding, that shadow, that density in that space will affect the patient. And kind of starting from front to back, we can say, well, what are they looking at? What is this person looking at? If you're looking at a bright overcast sky, you're up north in the wintertime and you have just the diffuse bright snow and sky and everything's kind of white and diffuse. If you're looking at an airplane window at the diffuse blue sky, a bright backlit screen, those homogeneous and plain and bland bright backgrounds will tend to make those shadows more contrasty. So again, you're looking at a white wall and you have a density there, it's going to cast a shadow. And that shadow will be particularly contrasty against a plain, bland, homogeneous background. Now, let's say, on the other hand, you picked out some groovy wallpaper from the 1960s, and it's got this sort of paisley pattern, bright, colorful, psychedelic pattern, or you're just walking through a dappled forest, a dappled shadow, forest with lots of different patterns and shadows, and everything's kind of all over the place. The shadow cast by that floater will be camouflaged, I guess, in a way. It will be kind of disappear in that busy background. So, and people will absolutely confirm that there's certain activities and certain environments that are just absolutely torture. Their office, everything's bright white, and big fluorescent lights, big box stores and things like that will tend to do that. So definitely, what are you looking at will be problematic. Now, another big factor is the size of the pupil. So the pupillary aperture. In the situation where there's a small pupil, and let's just give us a prototypical little density right there, that small pupil gives us a very small point source of light. and that light is coming in from a small opening, that will tend to cast longer, more distinct shadows. So even the very small floaters will cast long shadows. So people, in bright environments with small pupils, we tend to see more and more of them, and the outlines will be more distinct and defined, and that is just an optical phenomenon. On the other hand, let's say we blow that pupil wide open, or you're just at nighttime. Nighttime, pupil opens up a little bit, but let's say pharmaceutically, we put some drops in there and we dilate the pupil. Now the light source is coming in from a much broader light source. So that same small, dense floater will have light rays coming from this direction, which would normally cast a shadow in this direction, but coming from down here will cast a shadow in that direction, and they kind of negate each other. And what you'll end up having is a smaller, cone-shaped, shorter trailing shadow on that umbral side, that shadow side there. So the smaller ones may only cast shorter shadows, and so with a dilated pupil, you see less floaters. I dilate all my patients, and after treatment at the laser, I say, I don't expect any feedback from you right now because your pupils are dilated. And so you have to wait till tonight. You have to wait 3, 5, several hours. It's early enough that maybe by 6, 7, 8 o'clock tonight, then you can start doing the floater salute and comparing what the treated eye versus non-treated eye, and you can start to get an idea. Better yet, let your eye and your tear film and everything fully recover, come back tomorrow, report back on what we've accomplished, and then we'll know. So I've always been aware of what that dilated pupil would do to that. And you might say, well, why don't you use that to treat floaters? Well, we don't, but we do, but we don't. It would be impractical, if not cruel, to try to send people out into the world with a fully dilated pupil. There's a lot of light sensitivity. The more you're using, the more the peripheral parts of the lens, there's more optical aberrations, it's blurrier, and these dilating agents will paralyze your dynamic focusing ability. So for younger people, especially, that really knocks them out. So fully dilated pupil is just not the way to go. The low-dose atropine is a particular manipulation of the pharmaceutical properties of atropine, where you get a milder dilation that lasts about 24 hours or so. So I've added that to my practice and offer low-dose atropine, especially anticipating that it'd be helpful for the younger patients. And just by opening up that pupil, maybe 1.5 millimeters larger, is enough to reduce those shadows, those trailing shadows that they see. So absolutely, pupil size matters. And using the low-dose atropine is really not that much different than just putting on a pair of sunglasses indoors. Now, maybe at home, that's fine. You can work on your computer, all that kind of stuff. If you're in the corporate environment, or if you're at work, or in the service industry, you can't really be serving drinks or dinners, wearing your sunglasses indoors. That Mr. Cool look is probably not going to fly with your employers. All right, so that's that. Then the big one is, just like real estate, location, location, location. Where are these floaters located in three-dimensional space? Particularly anterior versus posterior. Where is it located in the? So if we were to say, well, the most anterior it could go would be the back part of the lens. The most posterior would be the back part of, the back where the macula is here. We have this anterior posterior distance. Generally, the closer the object of regard, this density, the closer it is to the retina, the more distinct, more defined, more detailed it's going to be. It doesn't necessarily mean it's going to be the most bothersome floater, but the quality of that detail is going to be very, very, very important. And so I'll often use the patient's drawing of what they see as a predictor, a prognosticator of where that floater might be, or at least kind of where to look. So virtually every time a patient comes in, I have a piece of paper and I have a little rectangle drawing, and that rectangle is supposed to represent, as I say, your visual field. And I explain it to them. If this is, isolating one eye, if this is looking out at, if you're standing, 4 or 5 feet away from a big white wall, if you could just kind of try to represent what you see as your floaters. And everybody says, oh, I can't draw them. I'm like, I know, I can't do it for you, so it's something you have to do. So I had 2 patients yesterday, and And these are two kind of extreme examples of how somebody might draw their floaters. So this is a guy who's about my age, and this is a young guy who's 31 years of age. Now, I don't grade people on their artistic skills, but there's a couple things to learn here. For the younger patient, what you see here is what I call detail within detail. Or I sometimes describe this as crystal worms. This would be like if you took a glass stirring rod from chemistry class and you laid it down on a piece of paper, you'll see both of the edges of that glass sort of refract and define the edges. And in this case, he's got all these little segments of that little crystal worm, or the worm, the segments. This is a lot of detail. This is classic for microscopic floaters that are probably just sitting right on top of the retina, because there's no way you'd see that kind of detail if it was further away. And then you have my 60-year-old patient who drew this thing. I don't know what that is. You know, it's a diffuse, cloudy something that he's aware of, but there's really no definition then in there. I mean, it's a black ink pen. He can't really shade as you could with a pencil here, but he's just trying to represent it's just diffusely affecting my vision, but not really with a shape. And these are the people like, I can't draw it. These people, these younger people, will draw it with great accuracy. Interestingly enough, well, in fact, no, when I asked him to draw this thing, and I come out and I grab this, immediately, without saying anything, immediately in my mind, I'm like, I'm going to spend about an hour and a half with this patient and ultimately render the opinion of I either see your floaters and they're too close to the retina, or I see maybe just a small fraction of what you've described here and it's too close to the retina, or they are so microscopically small and presumed next to your retina, I can't see them. And in all three cases, I can't treat you. So what ended up happening is I did a very thorough, very focused, hovering close to the retina, looking for this stuff, and ultimately shrugged my shoulders and said, I can't see them. And then I knew I was going to spend another half an hour explaining the optics of why I couldn't see them and why I have to be okay with that. And there was just really nothing to treat. But sent him off with some low-dose atropine, and he'd already been on it before. I tried a lower dose because he was a little symptomatic on the standard dose. And that's what I got. Now, I said earlier that a floater being proximal to the retina does not necessarily correlate with the overall bothersomeness of that floater. Here's an example. Let's say somebody has a relatively small primary floater sitting relatively close to the retina. You ask them to draw a picture, and they say, yeah, I've got this thing that looks like that, but it's out to the side. That's casting a distinct shadow. They'll draw it with great detail. But it might be out in the periphery, and they might say, yeah, it's kind of annoying. I'm aware of it, and it kind of moves in a little bit, and kind of moves out a little bit. I'm kind of always kind of glancing over at that thing. I think it's a mouse on the floor or something like that. But their central vision is not really being very affected, and this might be something that I might say, I can't treat that, and we might just have to leave that alone. On the other hand, something very, very far away from retina, I had this patient yesterday as well. He did have a Weiss ring. And if you know anything about me, I'm like, I love me a Weiss ring. Like, they are the most treatable, they're most efficiently treated. I go in that with the highest expectations of satisfaction. That wasn't the floater. What he actually had was something tethered and stuck in this range right here. And he had actually been treated elsewhere with a light treatment, and the doctor probably accomplished the task, because in his previously treated eye, he had that, and he did not have a Weiss ring. In his untreated eye, he had, just as I described there, a relatively small eye. I think what happens, the doctor treated the Weiss ring and said, mission accomplished, right? That is a relatively minor, slightly bothersome, hardly noticeable in this case, floater. What was happening is, as I asked him to look down and look up, this thing, this monster would come up and then drift back down again, and generally sit kind of out of the way. But that means every time he flicks his eye, looks down, looks up, this thing is moving across there. Well, if you're in a bright environment, if you have a big dilated pupil and that floater is coming up in that, well, yeah, that's going to affect the quality of vision. What happens when you have a small pupil? That thing comes up, it's blocking all of your vision. So if we have the same size floater out in the periphery, you might say, well, that's a bothersome but peripheral and not all that bothersome floater. If you have that thing coming up there, it's literally going to obscure or affect all of your vision. And he had this in both eyes. So he could be driving down the freeway 70 miles an hour and have both of those things kind of obstructing his vision for a couple hundred yards or so. Generally, the closer to the retina, the more distinct and defined and detailed that is. The further away it is, the edges soften up, it becomes a little bit more diffuse, a little bit less defined, and you start to get drawings that might be a little bit more vague, like this. Centrally located, and we're talking about down that visual pathway here, anything in this zone here is going to be much more bothersome than anything out in the mid or further out periphery, because central vision is more important than peripheral vision, of course. Captain Obvious here, something that is denser will probably be more bothersome than something equivalently sized but more translucent and transparent. Larger compared to smaller, larger one's going to be more bothersome. And it's the dynamic movement too. Like if that floater is drifting across and moving across, and that's kind of the definition of floaters, moving shadowy figures, moving, negative vision things across the vision there, that dynamic movement, your lizard brain is like, what is that? What is that? And you might have that examination and be reassured, or we can do that examination and reassure that patient that they don't have a retinal hole, don't have a retinal detachment, everything looks fine, the eye is healthy. I mean, that's the way I was trained. Somebody comes into your office with a dynamic moving shadow, some sort of new phenomenon, we're supposed to dilate, take a look around and say, the good news is you don't have a retinal hole or tear or detachment. But they're still quite bothersome. So the movement definitely kind of activates your lizard brain. So I guess what I was saying is you might academically override that initial concern of like, am I going blind? And you can override that with education and understanding and say, oh, no, it's just that, it's all explained by a PVD and a moving shadow. And so, yeah, I understand it. I don't have to panic. I've been reassured that my eyes are healthy. But then your lizard brain is like, what is that? What's that thing moving around? What's that thing moving around there? And it's kind of hard to turn off your lizard brain. So I hear this every day. My doctor told me it would just go away. And I'm like, how? Like, explain to me, I'm the patient's advocate. Excuse me, doctor, I'm this patient's advocate. Can you explain to me the mechanism by which you expect this to disappear? I don't know. There's no mechanism in place. Now, maybe a small floater initially with a PVD, if that were to move a little further away, maybe a month or so later, that might be a lot less bothersome. So there can be, in the early stages, in a few weeks or so, a little bit shift and drift. And in fact, for myself, if somebody says, oh, I just had this PVD yesterday, can you treat it? I generally say, give it some time. Let's give it an opportunity for this thing to move a little bit further away. It'll be better for treatment if we end up doing treatment, but let's give it a chance for it to become less bothersome on its own. You might, after a month or so, you might say, yeah, it was really bothering me that first week or so, but no, not so much. So it's actually, I can live with this and I don't need any treatment. Well, great, good. You don't have to do any treatment. Fine. Now, whatever the type of floater, the amount, the distance, the location, the dynamic nature of it, all of that is, again, negative information that falls onto the retina. The retina is vision agnostic. The retina don't care. The retina is just saying whatever light information falls on it, whatever photon, light, saturation, intensity, focus, defocus, cloudy, whatever, that information, I'm going to do a little local processing here, and then we're going to packet that up, and we're going to send that through the optic nerve back to the brain, and the brain can sort that out. It's the brain and your expectation for vision that might find these floaters really unacceptable. If you've always been used to clear, comfortable vision, binocular, stereoscopic, single clear vision, and now you have this thing moving around there, you're probably not going to be very happy with it. So that's kind of an agnostic processing of that information and an interpretation by the brain, which brings me to one of the very important factors that I call the filter. That's the, I'm used to drawing these things upside down. The letter psi, Greek letter psi, the psychology of that person. And that's something that you and I cannot predict that will walk through the door. My practice is full of professionals, engineers, software people, software engineers, entrepreneurs, and these are not the I don't attribute to like derogatory character, like, oh, they're type A, as if that's a bad thing. Oh, they're OCD, as if that's a bad thing. I smile because I have a little bit of that probably. These are detail-oriented, task-oriented, kind of performance people that are used to solving problems and doing the research and solving problems. And now they have this thing that very few people are offering them any solution to. Or if the doctor does discuss any potential solution to that, it's like, well, we could suck the juice out of there. We could do a vitrectomy and get that out of there. And they're like, oh, God, I don't want to do that if I can avoid it. And that explains their going to the internet and finding me and finding you. And that's how people kind of go about and find a potential solution for that. So, and it gets a little more complex than that. So, if we go to the old Venn diagrams from high school math, we could say, let's say this whiteboard here represents all of the world's population. And within that world's population, we're going to draw a circle representing all the people that have all various forms of floaters. Okay? Some people are going to have floaters. I don't know if that's a big circle. I don't know if that's a small circle, if it should be a smaller circle, if it should be, I don't know. A lot of people have floaters. Now, given enough of population, there's going to be a group of people that may have some tendency towards a little anxiety and depression. That's kind of their baseline. They may have a tendency toward that. It's not a judgment. Given enough of a population, we all come in different flavors. We all have different baggage. We all have different coping skills. And, health anxiety seems to be pretty common these days. A lot of people mention that. So that's some people that have that. And then maybe overlapping that, there's some people that have some even, more sort of obsessive compulsive disorder. They might have some of that too, where, they tend to really get focused on things. I don't know, where ADHD or something might kind of fit in that. I think that people who have sort of baseline characteristics like this may tend to really focus on that physical thing. These are more vague. These are hard to measure. Everybody's got a little this and got a little that and has good days and bad days. But that floater is a physical thing that is there. And so I think that this loosely defined group of people tend to really focus on that physical thing of the floaters. And so these characteristics just amplify amplify the bothersomeness of those floaters. So, if you're going to be treating floaters, this is not a mechanical thing. I say, kind of half jokingly, my practice is 90% optics, physics, anatomy, lasers, opal, 90% opal. 8% amateur psychology, amateur therapy, empathy, and 2% voodoo. Because sometimes you just can't figure out what the heck is going on. These floaters will not behave the way that you think they should be. Sometimes if you think you see, first of all, never say that a treatment is easy. Oh, that's an isolated Weiss ring. This should be easy. Trust me. Don't ever say that. Don't ever say that out loud. You can think to yourself, this is cleaner, a treatment. This is a more straightforward. Like, this is the kind of stuff I like to see walk through the door because I can anticipate having a pretty successful treatment, less likely to need a lot of treatment, less likely to have, reformation, nearly zero risk of elevated eye pressure. So you're certainly entitled to your preferences. My recommendation is never say easy. Some of these things will just not behave the way you think to. And then on the opposite spectrum, there are times where I'll look in there and I'm like, man, that's a lot of stuff. Like this is overwhelming. There is a lot of stuff in there. And I'm just a tiny, tiny bit of energy. Like I just have a little bit of energy with my laser, and I will sound very guarded and I'm very cautious. I'll say, but we could try. I mean, at least we could try. Maybe we'll get lucky. And some of those will be very efficient treatments, surprisingly good treatments, like such a blessing and such a wonderful thing. So that's the part that is just hard to figure out. There is just a kind of chaotic nature to this sometimes. Given the same looking floater, same amount of stuff, perhaps the eyes will just behave differently. So you have to be able to flex and bend and do what I call, manage expectations, and then remanage those expectations. And then when you think you're done with that, you need to go back and remanage those expectations as you go, and anticipate some setbacks like reformation. I tell all my patients about the possibility of reformed floaters, and even with Weiss rings, which are not supposed to reform, like I've seen just by poking around in there with the laser, you can get some reformation. It's a total unexpected, unanticipated, not very happy surprise, but you have to kind of work through that. If you don't manage those expectations and talk about that kind of stuff that might happen, you might end up having an unhappy patient. And if then you're trying to shuck and jive and explain it afterwards, it's just going to sound like you're making excuses. Here's the secret to my practice. Here's a secret of my practice. And if you've been in practice for a while, you'll either agree or concur or, I don't know, disagree. Human peoples are mostly forgiving of imperfection as long as they believe that you are trying your best, you're honest about what you're doing, you treat them fairly, that includes financially as well, and they know that you're trying your best. What people don't like, even if they can't quite verbalize it, they don't like being gaslit, they don't like being bamboozled, they don't like being blamed as being a slow healer, and if you've already pre-managed their expectations and told them about the possibilities of it might take a few treatments or more. The end point is hard to define. It's hard to know when to stop, when we should say that's good enough. There's the problem of reformation. If you manage all that stuff in advance, people will stick with you, and they'll come back, and you can have another chance at bringing that back down again and getting them back into a better place. Ask me how I know. I could talk more. I think this really covers most of what I want to cover in this. It's just you have to think about floaters differently. It's not vision. It's a diminution and a reduction of the quality of vision, and that's highly dependent on lots and lots and lots of variables, including just that individual who's going to be different from the next individual who's going to be different from the next individual. Anyways, I'll wind this up. This is another episode in my masterclass for eye doctors. If you stuck it through this far, maybe you learned something, and maybe you wish to learn some more. If you think that this information is interesting and you want to stick around, why not subscribe? Hit the notifications bell if you want to be notified when I drop another video. Share it with somebody who you think might benefit from this. And if you're a floater sufferer and doing your research, well, welcome. You're welcome to watch these. You'll learn something as well. And I got a whole wall full of Post-it notes with ideas to do more videos. So I have some long-term plans to do more of these. So I hope you enjoyed it. And until the next episode, thanks for watching, and we'll see you next time around.